Welcome to episode 54, Family Therapy with LGBTQ Youth, by Kyle Bullock, licensed social worker. From Clearly Clinical, learn, grow, shine.
Hello everyone, my name is Kyle Bullock, and I'm the manager of LGBTQ services at Garfield Park Behavioral Hospital in Chicago, Illinois. I am a social worker by background, and I've worked with LGBTQ youth in several different capacities over my career, from psychotherapy to youth development work and after-school programming. So this is definitely a population that's very near and dear to my heart. And today I will be talking about doing some family work with LGBTQ youth. In particular, I'll be going over 3 different family therapy models that we use really on a daily basis at Garfield Park Behavioral Hospital. They are 3 family therapy models that I think are really foundational really to doing good family work with LGBTQ people. So that'll be the focus of the podcast today, is reviewing these 3 models. This is not a LGBTQ 101, so I know that Clearly Clinical has several LGBTQ podcasts currently in its library, and one of those is an LGBTQ kind of 101 back to basics. So if you are tuning into this podcast and you haven't done any LGBTQ youth work before, I would definitely recommend listening to kind of the introduction back to basics podcast before listening to this one, because in this podcast I will not be defining terms. I will not be talking about any kind of history or kind of like how to do this work appropriately. As far as it's important to use pronouns. It's important to respect or be non-judgmental when working with this population. So I won't be talking about any of that. I'll be going right really into doing good family work. So a couple things I wanted to first start with is tell you a little bit about Garfield Park Behavioral Hospital in Chicago. We have a LGBTQ inpatient unit, which from what we can find, our hospital has the only standalone inpatient psych unit for LGBTQ youth in the country. The unit is called Polaris. We took the name from our North Star, because the North Star has been guiding people for centuries on a journey. So we believe that young people who are LGBTQ are also on their journey. I think we lay a good foundation for that. We serve children and adolescents only, ages 3 to 17, and we've been serving the Chicagoland communities for the past 6 years. And if you want to know more information about Garfield Park Behavioral Hospital, I'd recommend going to www.garfieldparkhospital.com, and you can see all of our services, and there's a link you can click on at the homepage to read more about our Polaris unit. So before I begin talking about family work, I think it's important just to kind of, this is kind of my little soapbox for doing this work appropriately. Like I kind of mentioned before, people who are going to dedicate a portion of their clinical work to working with really any marginalized and vulnerable population, especially if you're not part of that vulnerable population, like you don't share those particular identities. Excuse me. It's important for you to really understand any power and privilege that you have within your identities. So if you remember back to your grad school days, you might remember that LGBTQ people are of a marginalized identity, right? They lack a lot of power and privilege. So if you are listening to this and you are not LGBTQ, If you're not a gender or sexual minority person, it's important to reflect on your privileges and inherent power that you have in your identities as a potential straight, non-trans, or cisgender person. That's, I think, the key essential part to do this work well, is to really understand your own identities. This work is more than just LGBTQ 101. You have to really dedicate some time and study to do this work appropriately. These young people need and require your commitment to your practice, to better your practice by continuing education. If you remember, I don't know, 10, 20 years ago, there were terms that we're using now in this community that we didn't even use back then. New words, new identities come, into the forefront while old ones slip away. I mean, this community is known to constantly change language, to change identities, to invent new things. Young people have always been the movers and shakers of driving culture forward. So I think it's important to understand where queer and trans youth are directing us, because I think we have a duty as clinicians to respect and honor where they're at and move with them. So it's really more than just LGBTQ 101 that you need. It's a constant further of your education. I think it's important also to acknowledge your own struggles or challenges that will come up when working with this population. It's okay to get supervision. It's okay to reach out to your local LGBTQ organization and say, hey, I'm working with an agender, pansexual young person, and this is the clinical presentation. I need help. Right? That's okay. It's okay to acknowledge those challenges and those struggles. That's going to make you a better clinician. So continue to do that. Also, you have to acknowledge your role as a gatekeeper to mental health, particularly for this population. So if you're unfamiliar about what I'm talking about, that is, even still currently, there is a practice of, trans or gender nonconforming people needing to get a letter of hormone readiness, right, from a therapist, or they need to be in therapy for X amount of months or years before, usually a non-trans or cisgender clinician says, I think you're trans enough. Here's a letter now that you can go receive your hormones, right? That is a form of gatekeeping, and we have a history of that in our profession. So if you're going to be doing this work, you're going to have to understand where you fit within that power dynamic. Even maybe you're working in an organization or a practice that doesn't do that, and actually maybe you have your letter of readiness is maybe one session. Maybe it's an informed consent model, and it's your agency has moved away from kind of a prolonged assessment. But it's important to recognize the history and where you're coming from, because that's going to have an impact on your work with this population. Two more things I want to say before I jump in is honor the lived experiences of LGBTQ young people. You are not the expert. You may think you are because you might have 30 years of clinical experience and young people really, really well. Maybe you advanced degrees in child development. Queer and trans youth are unique, and their lived experience of who they are is their own experience. It's one big takeaway I tell mental health clinicians, psychiatrists even, that we need to honor these experiences, celebrate them, respect them, because these are, our young people's, way of being and their experience. So I think it's important that that we continue to do that. Also, last thing I'll say is don't get caught up in curiosity. I think a lot of us are curious naturally about people. I mean, that's why we're clinicians, right? Is that we are interested in the lives of others. But for queer and trans youth, and particularly transgender, gender nonconforming young people, there's a lot that we just don't know. And we're, I think, beginning to understand more. But I think what clinicians oftentimes fail to do is not getting caught up in curiosity, right? So there's a lot of research out there that shows that even medical providers will ask really inappropriate questions to trans and gender nonconforming people, parts about their body, questions about how they have sex. It's inappropriate. So, you have a wonderful tool available to you called Google or whatever search engine that you use that you can Google these things. Don't always rely in having your trans or gender nonconforming client tell you about questions just to or answer questions just to just for your own curiosity. So do that on your own unless the young person is telling you these things on their own free will and they're wanting to. So those are a few of my just little tidbits before we get started, because I think it's important to really commit yourself to this work, because if you're going to do it right, you have to educate yourself, and it's a constant learning. So I think you listening to this podcast is a definite step in the right direction. Okay, so I want to just quickly talk about what is affirming practice. I think this will kind of set the stage for doing family work, because doing good, culturally competent family work, you have to be an affirming practitioner. So I get the honor of providing a 1-hour orientation to all of our new hires at Garfield Park Behavioral Hospital, and I tell them that we need young people on our unit, on the Polaris unit, who are affirming practitioners. And that is really just an approach to therapy. It's an approach to nursing. It's an approach to psychiatry, where we value and embrace the positive view of LGBTQ people, their relationships, the negative influences that homophobia, transphobia, heterosexism has on the lives of LGBTQ people. And it's really our job as therapists to assist these young people as they face challenges that stem from an invalidating environment. That was a quote I picked up. Forgot where, but that was a direct quote. And also, affirming practitioners believe that LGBTQ people are a natural and normal reflection of the human experience. If what I just said, that LGBTQ people are a natural and normal reflection of the human experience, if you don't believe that to your core, you really can't be doing this work. You have to believe that and know that an LGBTQ person or a gender and sexual minority person is just like anyone who's tall or has brown eyes or black hair. We're just a reflection of a variation, right, of humanity. So I think that's important. And really the last thing I'll say here on affirming practice is affirming practitioners allow their clients to transcend restrictive social constructs. So a social construct is gender, right? Society has created that if you were born with certain parts, girl parts, quote unquote, you have to be wrapped in a pink blanket. You have to be feminine. You have to be, sensitive and nurturing. And if you're born with, quote, boy parts, you're wrapped in a blue blanket, you are aggressive, you're manly, right? There's nothing in our biology that says that's true. Society has created that. We know this is the fact. Social science has determined this, right? So affirming practitioners allow young people to move beyond these boxes, these very rigid boxes in these binaries of, you can only be male, you can only be female, you can only be gay, or you can be straight. There's so much gray out there that we have to allow young people to break free. I've worked with young people before where our therapy sessions, especially the beginning months, were just, where are you today? Who are you today? And how can I celebrate that? This young person, each time they saw me, it was a different name and a different pronoun. That's fine, because the therapy space was the only space that they had in their whole world where it was safe for them to do so. School wasn't a place for it. The home environment was definitely not a place for it. So it was the therapy space that we created together that allowed this young person to explore their gender. I allowed them to transcend that. I said, you don't have to fit these boxes unless you want to. That's great. I'm here to support you wherever you want to go. I don't think young people get that opportunity very often. So really, and you know what's interesting is that I've seen a lot of clinicians who begin to do this work and allow their patients, clients, whatever name you use, to transcend restrictive social constructs, is they begin to do it themselves, because they begin to free up a part of themselves. And I've seen a lot of people blur the lines. It's actually, I think very inspiring. So, don't be afraid if you start to transcend your own restrictive social constructs. Okay, so let's talk a little about these three models. The first model is called Helping Families to Support Their LGBT Child. This is from the Family Acceptance Project out of San Francisco State University. You can go to familyproject.sfsu.edu. They actually have some great free downloadable material on their website. So the Family Acceptance Project out of San Francisco State, they have this model, the Helping Families to Support the LGBT Child. They have downloadable practitioner guides and then a family guide as well. So actually the family guide, you can download it in English or Spanish, is a guide that we give to every family when they're discharged from our LGBTQ unit at the hospital as good psychoeducation. Because the Family Acceptance Project was really the first organization or first research project that put data to support what we already know as clinicians, that families who reject their children put them at risk for suicide, depression, HIV, and drug use. We know that. That makes sense to us. At least it does to me. I'm not going to speak for every clinician out there, but I think we have an innate sense about how our families can impact functioning, right? So they were really the first organization that put that out there and put data to it. And then on the flip side, they have data to show that if you support your child and accept them, you decrease risk. And I tell every new hire at the hospital that we are in the business of decreasing risk. So of course we're going to support young people and wherever they're at and use their names and pronouns here at the hospital, because we want to reduce their risk. And oftentimes young people are coming to us in their darkest and lowest time. So we would not want to bring up any feelings of being unsafe if we're not using or respecting their identities. So this model from the Family Acceptance Project has 7 steps. So we're going to go through each one. The first step is to just engage, approach, and connect with families and caregivers by meeting them where they are. I mean, how many times have we heard that phrase as clinicians, right? We just meet people where they're at. families of LGBTQ young people, they come on a range usually of from one end accepting to the other end rejecting. And it's a whole bunch in between. So it's really meeting them wherever they are along that continuum and viewing each family as an ally. Now, that is very difficult, especially because I know we have biases as clinicians. We have judgments, and if a young person is coming to you and they're saying that they're not accepted as a trans girl by their family, the family members say really awful things about them, really put them down, and it really hurts this young person and causes them distress. I don't know about you, but I'm going to be not thinking very highly of this family member. And then when they come into the session with you, how do you align with them when this young person has told you all these things which you know increases risk? What do you do? I remember working with a young person once, a trans girl, and I did not view the father as an ally at all. I didn't value their traditions, their cultures, the family unit as a resource, and big mistake because I lost the dad right off the bat. It took me some time to get him back and build that alliance with him, but I didn't view him as an ally. I immediately viewed him as dangerous, someone who I needed to change in the therapeutic relationship, and that was my goal for him. But everyone is at a different place, and I think we run the risk of losing people if we push them too hard. Also, part of step one is to start off from a place of protection. If a family is coming in highly rejecting, we reframe that behavior, the rejecting behavior, as, you know what? You want your child to be safe and protected from harm and danger. And being an LGBTQ person can be dangerous. You don't know what your child will do in the future, if they'll be harassed or jumped down the street or called really awful names. Like, how do you protect them from that? So oftentimes what I've found in my practice is that rejecting families are coming from a place of fear, and they're wanting to protect their child. So they say, nope, you can't be gay, you can't be trans, because I'm protecting you, right? And also, there's this idea that I can accept you and support you as gay or trans or whatever, but only in certain instances and only in certain places. So I had a family that I worked with who the mom said, I love you as you're my gay son. I accept you. You're wonderful. You're beautiful. I love you. And the young person was very excited about that. But then the child wanted to go to a family reunion and got in the car and was ready to go to see all of his relatives. And the mom saw that he was wearing a very kind of openly gay t-shirt with a rainbow unicorn on it, and might even said I'm gay on it. And the mom said, you cannot wear that shirt. Please go take it off. It is not appropriate for this reunion. Now, that's a mixed message. So if a young person is hearing, I love you and support you, and not today, that can be challenging for a young person. That's oftentimes I hear in a big disagreement between family members or the child and the parents or guardians is, I love and accept you, but, right, or not today or not in this way. So it's a big mixed message I think it's important for us to catch and work with and really kind of expose. The second step in the family, helping families to support their LGBT child, is letting the parents tell their story. Oftentimes, parents, guardians of LGBTQ adolescents need to grieve the loss of what they thought their child would be. Oftentimes, if a baby is born and the physician puts a blue blanket around it because the baby has a penis, and they say, it's a boy, the parents begin to have this idea of what their child will be like. And it's usually straight and it's usually non-trans, right? Oh, my baby boy will get married to a girl and they'll have babies, they'll have the white picket fence. And then the young person comes out as not that. It can really disrupt the family unit. So we really have to give parents some time to grieve that loss. And in fact, I'm not sure how you'd be doing family work in your practice, but I've often told family members separately, I said, yeah, I think you need to find your own therapist because, you have stuff you need to talk about and explore, but in the family sessions, it can't be all about you. We're working to repair the relationship, whatnot. But, oftentimes families will have to find their own, their own help. Because oftentimes it's just too much for us to do, right? The third step here is to give families respectful language to talk about sexual orientation and gender identity. Hence, you need more than an LGBTQ 101 training to do this work because parents are going to ask you questions about, my child wants to go on puberty blockers. What is that? Should I do that? Or, my child says that, he's on Grindr and he wants to hook up with boys. What do I do? First of all, you're going to have to know what puberty blockers is. You're going to have to know what Grindr is, right? You're going to have to know some of these terminologies in LGBTQ youth culture and definitions. They're going to say, I don't know what, agender or, panromantic or, young people are so creative and clever. They're going to be asking you as a clinician to define some of these. Not that I'm not saying that you have to know everything about LGBTQ youth, but you have to know some, and you have to know where to point them in the right direction to find appropriate, accurate scientific knowledge, right? So that's a part of, really committing to do this work is because this is not just LGBTQ 101. You have to have a good working knowledge, especially if you're working with a trans, gender nonconforming, non-binary young person. You have to give them that language. It's so important as a clinician because, in fact, a little story about this is I was working with a family, and I had a session with dad, just dad. And I said, Dad, I think it's time for you to start using your child's pronoun. And I told them why, and gave the dad some research that says that if adults honor and respect a trans person's name and pronoun, we reduce risk. And again, we're all about that. That's our business. And I said, I think you have to be doing that, or at least thinking about it, or trying to incorporate it, right? And then in the family session, I brought the young person in, and dad used the name and pronoun of this kid, and the kid was shocked, right? But that was because I gave dad some information, right? And I was able to kind of contain it in a very safe space for him to do. So that's step 3. Step 4 is to educate families on how family rejecting behaviors affect their LGBT child. So I want to list some of these rejecting behaviors. So these are things not to do, right? Physically abusing a child due to their identities, obviously. Verbal harassment, excluding youth from family and family events for being gay. Like that mother did, was trying to do with her child. Blocking access to LGBT friends, events, and resources. Blaming a child when they are discriminated against because of their identities. You got pushed into a locker. Yeah, it's because you're gay. That's a no-no. That's going to increase risk. Blaming a child when they are discriminated against because of their identity. Or I just said that one. Pressuring a child to be more masculine or feminine. Telling a child that God will punish them for being LGBT. Telling a child that you are ashamed of them or that they will shame the family. And making a child keep an identity secret. So if families are doing that, they are 8 times more likely for their child to attempt suicide. The child is 6 times as likely to report high levels of depression. The child is 3 times as likely to use illegal drugs and 3 times as likely to be at high risk for HIV and sexually transmitted infections. So I always call that step kind of the scary statistics. And I've really seen it work. I truly have, where families, this light bulb goes off. They're like, wow, I did not know I was putting my child at risk. And oftentimes families take a big 180, and once they realize, that their child is at risk, they're putting their child at risk. The 5th step is to educate families on how supportive and accepting behaviors affect their child. Those are, let me tell you a few, that can reduce risk. These behaviors are: talk with your child about their identity. Express affection when your child tells you or you learn that your child is LGBT. Support your child's identity even though you may feel uncomfortable. Advocate for your child when they are mistreated because of their identities. Require that other family members respect your child. Bring your child to LGBT organizations or events. Talk with clergy and help your faith community to support LGBT people. Connect your child with an LGBT adult role model, to show them options for the future. Welcome your child's LGBT friends and partners to your home. Support your child's gender expression. And believe your child can have a happy and healthy future. Number 6, or step 6, is getting families to a point where they know that they can reduce risk just by making little tiny steps. Okay? That even if they don't fully accept their child and is marching them, down with them in the pride parade carrying a rainbow flag or a trans flag, we don't need that drastic improvement in one session. Ideally, it would, from personally, that would be great for parents to get to. But little steps make a big, big difference in reducing risk. So that's like this father who said, who used his child's name and pronoun in session. That was a little step, right? On the other side of that, I had a young person who was just really beating themselves up over their parents not accepting their identity. And was just, and like adolescents are in their development, it's hard for them to see into the future and to see kind of, if they wait for certain things and outcomes, that, things will come in time. It's hard for young people to see that, so I get it. But I was working with this young person, we're talking about their family constantly, and the young person had this epiphany in the session and just kind of paused and said, I think I just need to give my parents some time. What an incredible, place to be at. This was a 13-year-old who found that it'd be better for their mental health, quite frankly, if they just accepted where their parents are and allowed them to be, and allowed them time. The final step is that, this is just repeating a little bit of step 6, is a little change makes a big difference in decreasing family rejecting behaviors. So that is from the Family Acceptance Project. That model is helping families to support the LGBT child. Like I said before, I would really recommend going to their website and downloading these materials, because I think they're very, very helpful. Again, there's a practitioner's guide, and then there's a family guide as well, both in English and Spanish. I believe they also have a model on their website for working with families who are LDS, Latter-day Saints, or Mormons as well. All right, so the second family model I'll be talking about is the multi-dimensional family approach, gender nonconforming families. So this was research from Malpas in 2011 in the Journal of Family Process. Really, again, so the Family Acceptance Project is really LGBT in general, okay? Malpas talks about like trans and gender nonconforming in general, okay? And there's some, I think, clear distinctions between the two. So the main kind of goal for this model is that families who have gender nonconforming children need to negotiate interactions between two gender systems. Okay, this is going to take time and therapy, right? But we want to get them to the point where there is a rigid gender binary that's imported from their family experience, their social experience, their cultural experience, that really tells them that no, there are only males and females. Very rigid. And then on the other hand, you have a very fluid gender spectrum that's articulated by their child. So you have two things that are both true, if you're thinking about DBT and dialectics, that they're both true at the same time, even though they might seem totally false. This rigid system, gender system, and then the system that their child is expressing. Also in this model, it'd be great if we can get children to the point where they can both affirm who they are, I'm a trans guy, great, and also understand the demands of a world mostly organized around a gender binary, right? I think young people are so idealistic, bless their hearts, but they're going to most likely be navigating a world where it's still widely constructed by the binary, right? So how do you get them to be who they are and love who they are and express who they are, but be prepared, right? To face a world that is organized around something that's very different from what they're experiencing. For parents, we need to get them to a place where they can both nurture their child's singularity as a person and operate as a mediator between the child's wish and the social reality, right? It's getting parents to a place where they can kind of help put their arm around their children and create that kind of nurturing space. Because if you've talked to a parent of a transgender non-conforming child, you will realize that it is hard. It's a challenge because I think a lot of, where our culture is, we understand the L and the G and the B, well, maybe not B so much, but lesbian and gay, we get it. Okay, you're a guy who likes other guys. Okay, great. It's still in the binary. But when we start breaking that apart and we're talking about gender, parents get really confused. This is why doing work with trans young people and their families really takes some skill and some expertise. The parent's goal for this model is to increase their acceptance of their child's fluidity and facilitate harmony between their child and the child's environment. That's really the main purpose of this model. There are 5 major components. The first one is parental engagement in education. So that's really kind of doing kind of a gender assessment, if you may, from the family perspective, from the parent guardian. Inquire about what have their responses been to their child's atypical gender journey. This often includes shock and fear and anger and sadness and shame and even disgust. And that, those feelings easily get entangled with their ability to feel acceptance and pride in their child, right? It's also in this first step is providing psychoeducation of what it means to have a trans child. They're going to be asking you a lot of questions, like I said before, about gender transition. What is a social transition? My kid keeps saying he wants to do it. You're going to have to know some of these things, right? Unfortunately, I don't have time, and this presentation really isn't geared to talk about these things in depth. Another point in step one is really providing, part of the psychoeducation piece is providing families with the knowledge that, gender nonconformity is a normal human expression, and predicting the future of where your child will be is nearly impossible. We don't have a crystal ball. We're not that type of clinician. We can't see into the future. And it's hard for parents to kind of sit in that ambiguity and be like, I don't know what that means. Like, will my child be a girl? Is my child a boy? Like, then you add on top of that non-binary. I mean, it gets really confusing for parents. But I think good psychoed would include, we just don't know trans trajectories. They're all over the place. I mean, humans are unique and they're complicated, they're complex. There is no single trans, coming out experience, right? People come out at many different ages for many different reasons, right? So just because you have a gender nonconforming child doesn't necessarily mean they're going to be a trans adult. And it could. We just don't know these things, right? The best thing we can do is simply love our children and nurture them for who they are and what their interests are. Because if we don't, we really run the risk of increasing risk. And I don't think any of you want to do that, right? We'd have to really review the differences between sex, gender, and sexual orientation. This is going back to the LGBTQ 101 training, Back to Basics, which you can listen to after this, or even to pause this, listen to that, come back. The presenter does actually great job kind of breaking these things down. But we're going to have to discuss these. We're going to have to give good definitions and good education to distinguish between those three. The second step is kind of the encounter and assessment with the child. So in this model, the first step is just getting information from the parents, kind of let them tell their story, grieve the loss, which, again, I'm incorporating that from the earlier Family Acceptance Project model, but again, I think it easily can be useful here. But in step two is really kind of creating that therapeutic space. It's kind of what we do naturally and do well, building a rapport, and doing a gender assessment, assessing where they are, what their future hopes may be. And again, doing a good gender assessment is a skill. It's a talent. And fortunately, we don't have time to really discuss them in detail here. But, I would encourage any of you listening to get further training on how to do that. The third step is my favorite. It's parental coaching. Oftentimes, these parents are hopeless, right? They are confused. They don't even know where to start, right? We need to coach them to a place where they feel useful again. And I've seen this all the time. I don't know what's going on. I don't know how to parent anymore. It's like I have a new child. They're saying all these new things. I'm not useful again. So it's getting parents to a place where they can be a resource for their child. Again, this takes time. So part of the parental coaching model is we have to balance, on one hand, the really unproven influence that parents think they have over their child's gender, right? No, you are a boy. You are wearing boy clothes. It's unproven that's effective. And in fact, it creates a whole mess in the family home. And again, it increases risk, right? So we have to balance, on one hand, that unproven influence, and on the other hand, the impact they can have on their child's self-acceptance, well-being, emotional and social adjustment, as well as safety. So it's moving past this unproven influence to say, listen, there are things you can do to still parent. You can be useful. Renew their sense of possibility. In this stage, I've seen parents go from clueless to activism when they finally are armed with enough knowledge of their child, and they say, you know what? My child deserves to use the correct bathroom at their school. Or, you know what? I'm reviewing the discrimination policy at my child's school, and they're not talking about sexual orientation or gender identity, gender expression at all, and my child needs to be protected. So they march down to the principal's office and they bang their hands on the table and say, I need you to support my child. Parents become useful again. They can advocate for their child, right? They can now make appointments for their child to find, with maybe a gender affirming physician or whatever. Like, they find this purpose again. And when you see it happening, it's really, really amazing. The fourth part in this step is the family therapy. That's when, after we've done the parental encounter, the child encounter, the family coaching, we finally get into therapy. And really the goal is to support a positive and functional family climate where parents can attune to the gender identity of their child, and where in return, they can respect the limits set by their parents, right? So children are going to have to be included within this, and to allow that, or to know that you are in mom and dad's house and they have particular rules, right? And if they're going to love and respect you and support you, you use the right name and pronoun, you got to clean up your room. I mean, really, children have to realize that they are part of a family and that there are certain things that they might have responsibilities, right? The second goal in the family therapy is repairing the relational bond. And that's really kind of focusing on their attachment and using some of our attachment theory and incorporating that into the family therapy, which we'll talk about next. That's our third model. So, that's where the family work begins. And that's really where the healing begins. But there's a lot of things that happen before that, right? To get them to a point where they can all talk. And then the last part on this model is helping the family find a LGBTQ community for them. So I often direct families to PFLAG, which are parents and friends of lesbians and gays, and they've actually become very trans inclusive. But it's the nation's oldest and largest support network for families. So you can go to pflag.com, you can click on Find a Chapter, you can type in your zip code, and you can find the closest chapter to you. But some places might even have a specialty, and they might have a Parents of Transgender Individuals group. So parents need that community. They need to be in social, communication, support. They need all of that with others. So I think that's vital. And in fact, I would say 95% of our patients that we discharge from the Polaris program have some sort of parental support recommendation for discharge. All right, so the last model I'll be talking about is called attachment-based family therapy for suicidal lesbian, gay, bisexual adolescents. That's by Levy, Rusin, and Diamond in 2016 from the Australian and New Zealand Journal of Family Therapy. Now, two things. One is that this research, I think this was a 16-session, therapy model, was only done with lesbian, gay, bisexual young people. However, I think this can really easily translate to trans, gender nonconforming people as well. But again, just their research was done on lesbian, gay, and bisexual young people who are suicidal. Um, the I think there is, if you Google this study, they have a case study that they publish, and then their research too. So I think the case study is fantastic. The title of it is Attachment-Based Family Therapy for Suicidal Gay and Lesbian Adolescents, a Case Study. Okay, so if you find it, read it. It's brilliant. It's beautiful. They go in each, they talk about each step or each phase of the model, and then it has a script. Really, you're going to see in session how the therapist did this work. It's really, out of all the articles that I've read, as I was developing our Polaris program at the hospital, this one resonated with me the most. So there are 5 components. One is relational reframe. I'll just start talking about that first. So that is really focusing on the hurt and disappointment that both the child and parent are both feeling. It's reframing parents' emotions, their criticism, their rejection, really stemming from a control, or stemming from that they have a deep love for their child, and they're concerned for their child. They're wanting to protect them, right? This goes back to the earlier model. They want to protect them, but it's coming out in a form of rejection, okay? Also, reframing the child's emotions, anger, withdrawal, as reactions to their own disappointment at their parents' response to their identities, and really that their suicidal ideation as an expression of hopelessness about the possibility of change. And also the last part of the relational reframe is it acknowledges both the child and parent's frustration and anger, but focuses on their mutual sadness about their emotional distance and longing to connect. I think that is so important to say you are both hurting. You both want to connect. You both want to love each other. There's something there. Yet, what is happening right now is pushing the two of you away. Their attachment is rupture, right? Essentially what it is. So it's kind of reframing their experiences, the first. Like I said before, I haven't said this before. So the first is relational reframe step. The second step is adolescent alliance building, which I'm not going to get into. It's really building rapport. It's knowing your stuff around around trans LGBTQ youth, right, and working with them, the unique, the uniqueness of their identities, knowing what resources they might need, knowing about puberty blockers, all these things. So it's building that alliance. The third part is parental alliance building, which is really just connecting how the parents' past attachment history might be influencing their parenting and the current problems and the disconnect between the two of them. And it really just it also includes in this step just building rapport, right? And we do that really well, so I don't really want to get too much into it. The fourth is where the magic happens. This is repairing attachment. And really it's the goal of the family is to have a corrective attachment experience where the adolescent brings up emotional problems related to the parents, and the parents provide comfort, protection, and sensitivity. I was working with a father and a child who was trans. The child was suicidal for many years and was telling Dad, I need help. Dad just kind of pushed it off, brushed it off, said, you're fine, just, be happy. Finally, the child came to us, had a suicide attempt. And the child said, I don't really know if I want to go home with Dad. I can't trust him. So there was a rupture in their attachment. Through our work together, Dad said, I'm just really disappointed and I'm upset, I'm angry. And I let that sit there. I said, who are you angry with? And he thought about it, took a long pause, and said, with myself, I have failed you as a parent. This was a turning point in their relationship, because finally the young person heard from dad that he needs to do better, right? That he is messed up. Dad said, I love you, and I didn't know that this trans thing was this important. I didn't know that you're really struggling. I want to be there. I will be there for you. And then they hugged, and they were both crying. And it was just a magical moment between these two, where they found, they had this corrective attachment experience. And after the session was over, I pulled the young person aside as I'm walking them back to their room. I said, so how do you think it go? And they said to me, wow, I didn't expect my dad to do any of that. I want to go home to him. I want to give dad another chance. So it was a really wonderful moment between the two of them. And I think using all these models and the information I know and the experience I've had with young people, I set a stage. I set a therapeutic environment where the father could get there, where the father could say, I'm angry with myself that I failed you, right? So that was just a little story that I have that I always think about in doing this work, is parents can get there. This was a father who was highly rejecting of his child's identity, highly rejecting, but acknowledged his shortcomings and decided that he wanted to do better. And the very last part of this model is promoting autonomy, which is really shifting away from ruptures and on to challenges in adolescent's life, and the parents are really serving as that base of support. It's dad saying, throw anything at me, let's tackle it together, I gotcha. That's where we want parents to get to in this model with their child. But again, a lot has to happen for any of this to happen. So those are the three models that I think are just simply foundational to do this work really well. It is providing good psychoeducation. It is setting the stage to have a corrective attachment experience. It is it's getting parents to a place where they find themselves useful again, that there's a point to their parenting. It's a challenge to have an LGBTQ child today, especially if, this is new and foreign and you don't have your own support, or a parent is not surrounded by an inclusive community. There's a lot of barriers for parents, but I think we have such a unique opportunity to promote a healing environment that I really hope that these three models can really benefit you, and I encourage you to read over them, and I think again this is really good foundational work. So that really concludes my podcast to all of you. I wish you all of luck in your professional lives. Just the fact that you're listening to this speaks so much. We need clinicians out there who are going to be doing this work, because we're only going to grow. I mean, this community is only going to expand. There was a study in California that I read that 27% of Californian youth, which is about 800,000, identify as gender nonconforming. Right. So this is a train that's a fast-moving train headed towards the unknown, driven by queer and trans youth. They are at the helm. We need to jump on board this train. We have to, or else we're going to be left aside. Our client base is going to dry up, and we're only going to be known as treating straight, cisgender people where that's just not the reality anymore. Young people are telling us otherwise. And it's a beautiful, beautiful thing that's happening with gender and sexual orientation that I really encourage you to jump on board the train too, because we need you and our young people need you. And this will save lives. So best of luck to you in your future, and have a great day. Goodbye.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.